Good morning, everybody. Thanks, Miriam. We're going to go ahead and get started. It's my pleasure today to be introducing Dr. Drew Ayars. So Dr. Ayars got his undergraduate degree here at the University of Washington before leaving to go to medical school in St. Louis, and then completed his internal medicine residency at the University of Colorado, and then returned here to the University of Washington, where he completed his fellowship in Allergy and Immunology. He is currently an assistant professor in the Division of Allergy and Immunology, as well as the associate director of the fellowship program. He attends in the clinic here at the University of Washington and also at Seattle Children's Hospital. He is a PI on a phase 3 clinical trial here and has authors multiple manuscripts and abstracts. He's also given many talks in the region, as well as been a guest on NPR. So it is my pleasure today to introduce Dr. Ayars, who will be talking today about allergy and immunology for the internist.
Thank you, Rachel. Thank you all for coming. I know the party was last night, so I'm glad to see all the people show up. So thank you for inviting me to talk about a field that I obviously love a lot. It's a field that I had a lot of exposure to growing up, having a dad who is an A&I physician. One of my colleagues, Matt Altman, his father's here, so there's a very familial interest in this. But unfortunately, in our field, there's not a lot of exposure during medical school and residency, and partly that's our fault. So part of the reason I'm thrilled to talk today is basically explain what we do. The initial title of my talk is A&I. What the hell do they do all day other than allergy shots? You know, and I think that's where the med students, residents come in and they wonder. So just as far as where I'm going to focus today, I'm going to focus it more on the inpatient side of things. That's where we get most of our consults here, mainly drug allergy, angioedema, and immune deficiency, which a lot of people do not realize that we do as a specialty. So I have no disclosures relevant to this talk. So in allergy, what do? Well, we do a lot of skin testing and allergy shots, which is actually amazing. This is our major journal, Journal of Allergy and Clinical Immunology from 2000. And that marked the 100-year anniversary of using allergy shots basically in the same form, basically giving people what they're allergic to. Now, we know a lot more about why they work, blocking IgG antibodies. There's a lot of different ways that they work. We have great studies showing they work, and they're still our best therapy, but there are new therapies coming down the pike. There's sublingual immunotherapy that they've been using a long time in Europe that was recently approved by the FDA for GRAS, and we should have some more coming down the pike. So this may change, but overall, management is the same. Now, most people were able to keep off allergy shots with our new medications and things of that sort. Asthma. Again, I'm not going to talk a lot about this. I do East Side Grand Rounds later in the year, where I'm going to keep it more focused towards outpatient management. But I am going to talk about one form called aspirin-exacerbated respiratory disease. I tell everyone that asthma it's like anemia. It's like arthritis. There's a lot of different pathologies that lead to the same clinical endpoint. And if you can tease out which type of asthma they're more consistent with, you can tailor that therapy, and that'll become increasingly important as we go down the road. Urticaria, again, that's more outpatient-based, but we see a ton of this, both the acute form, which is often IgE mediated, and then the chronic form, which is thought to be an autoimmune type etiology. Again, that's outside of the scope of this talk, but we do have a lot of new therapies that are coming down for that form, which is not life-threatening, but very bothersome to those patients. If any of you follow them, know. Angioedema. I was originally going to leave this out of the talk, but we've gotten a couple inpatient consults in the past few weeks regarding angioedema, both hereditary as well as ACE-induced angioedema. So I'm going to talk a little bit about that and torture you with the complement cascade. Again, I'll be talking more about this later in the year, but food allergy, it's becoming more and more of a problem. Our classic management was skin testing. If you have a true allergy, here's an EpiPen, good luck. Try and avoid it. If not, use that EpiPen and, Godspeed. But there are new therapies coming down the pike, and I think we're positioning ourselves here in the Seattle area to be on the forefront of that. We've combined with Seattle Children's, UW, Benaroya, which does a lot of the basic science research in this, and we're finally getting funding to study this ever-growing problem, which causes some mortality, but a ton of morbidity for the people that have peanut allergy, and especially their parents. Drug allergy. I'm going to talk a ton on this. We get 2 or 3 inpatient consults a week on drug allergy, so I'm going to give you the way that I deal with it, and a simple way to kind of think about the common issues that come up with this. Now, we see a lot of rare disorders, mast cell mediated disease, mastocytosis. I guess it's not rare here. We have 15, 20 patients. And we also see hypereosinophilic syndrome, which again is a rare disorder, and I'm not going to talk a lot about it, other than to say, if you do have a hypereosinophilic patient, we do have a protocol here through Glaxo, which is a compassionate use protocol with mepolizumab, which is anti-IL-5 and basically melts these eosinophils away. We have patients on 30, 40 milligrams of prednisone and still struggling. We put them on this drug, and we're able to take them off all their immunosuppression. So if anyone has any of these patients, let us know. We can see if we can get them on this protocol, because the drug is also very safe. So, what a lot of people don't realize that we do is the primary immune deficiency component. And in general, the younger trained ANI docs are more proficient at this, and it also depends on where you train. You know, down the road here, we have one of the top primary immune deficiency centers in the whole world. Hans Ochs, Troy Torgerson, Suzanne Scota-Smith are world leaders in this. So we're very lucky to be in this area, and you will see these patients if you have not already, for two reasons. One, these pediatric patients that we're diagnosing that used to die very young are now living lives into their teens, 20s, even normal lives with our new therapies that we have. Also, as you'll see in some of my later slides, the category of primary immune deficiency has expanded a ton, and I'll show you that in later slides. They've also expanded it to include immune dysregulation. So we're seeing a lot of the same patients as our rheumatologists, our hematologists, our pulmonary docs. So to use a bad cliche, oftentimes it takes a village with these patients. You will see these patients if you haven't already. We have two common variable immune deficiencies that we've seen inpatient in the past 2 weeks. I think one is still here. So there's a large population. We probably have 50 of these folks, and children's probably has 100 just in the Seattle area. So they do pop up more frequently in ERs and hospitals. So let's start with a drug allergy case. We've all seen this clinical scenario. 65-year-old comes in, ICU, community-acquired pneumonia. You want to start a third-generation cephalosporin. As with all drug allergies, unfortunately, for the most part, there's no good blood test, skin test. It comes down to history. She states, I had the rash in my teens, I believe, came on after several days, and that's always followed by, I'll never touch that stuff again. Denies any severe rash, meaning blistering, meaning involving the mucous membranes. Doesn't remember being short of breath, lightheadedness, and also doesn't remember anyone telling her she had problems with her liver, kidney, things of that sort. So, you have a few options. You can start Astrianam. And I'm going to talk about a program here at UW that we have teamed with the antimicrobial team, Paul Pottinger and Rupali Jain, about trying to cut down on Astrianam use. You could start the second or third generation cephalosporin. That comes down to knowing the cross-reactivities. You could start a penicillin drug. It's gutsy, but you could do it. You could also start a fluoroquinolone or any other drugs. But I'm here to convince you, since you wanted to start that initial drug, that there is a right answer to this question. Another question, I get this in clinic a fair amount. You know, someone comes in, you start them on Lasix for lower extremity edema. A couple hours later, you get a call from the pharmacist saying she has a sulfa allergy. The pharmacist asks, it was after a course of Bactrim several years ago. So from a medical legal standpoint, can you say there's really no cross-reactivity between those two sulfa groups? And we'll talk about that. So if allergists ruled the world, the first thing we would do if we took power would be to get rid of the drug allergy list. It would be called the adverse drug reaction list, because as most of you know, most of them are true allergies on that list. An adverse drug reaction is any unintended consequence of a drug, and they're generally predictable and based on the metabolic and pharmacologic principles of that drug. Now, allergic reactions, or the immune response, it's usually a response of the adaptive immune system to otherwise very benign drugs. It oftentimes will generate immunologic memory. And I'm going to tell you the way I classify these things. I always try and classify the allergies into the immediate versus delayed type reactions, and we're going to go over that in the next few slides. So here's how I picture all drug allergies, and I go through many different drug allergy cases a day. I try and classify them into type A, which is related to the pharmacologic principles of the drug. An example is aminoglycosides and renal failure. If you give anyone high enough doses long enough, you're going to have that side effect. These are some of my favorite on allergy lists over the past few years. Dilaudid makes me sleepy and confused. Well, it does that. It doesn't mean you can't have other drugs in that class. Even a lower dose of Dilaudid likely will help out with that. This is one of my favorites, too. Insulin makes my blood sugar too low. It wasn't low, it was too low. And she was convinced that was a side effect of the drug, and she could not have insulin anymore, despite the efforts of the PCP and myself. And sometimes you really have to talk to these patients because they love holding on to their allergies. Aspirin makes me bleed. Did you have a major bleed? No, I cut myself shaving. But he was convinced if he went into an ER, had an MI, he could not get aspirin for this. And oftentimes it takes counseling. So allergic, there's a lot of different ways to classify this. Again, I try and keep it simple. Immediate versus delayed. There's another way to think about it, the Gell-Coombs classification I'm going to go over just because there's a lot of implication for boards and things of the sort, but I'm going to go over those in my next few slides. Pseudoallergic. Now, it's important to tease out what reactions are likely to cause a pseudoallergic reaction. Contrast, vancomycin, opiates, and aspirin. I'm going to go over a few cases involving that. I'm not going to go over intolerance. That's GI upset after antibiotics, and even most patients realize that this is not a true allergy, and most of them are willing to try the drug again if they absolutely need it. So IgE mediated, or the classic allergy. You've probably all seen this. It's scary when it happens. We do studies in kids where we actually have to put them into anaphylaxis to qualify for these studies. And I'm always impressed, even in that controlled setting, how rapid this can be, how severe this can be. It involves multiple organ systems. Anywhere you have mast cells that release their vasoactive and histamine components. Wheezing, chest tightness, shortness of breath, lightheadedness. Those are questions that I always ask. Diffuse rash. Was it after the first dose? And again, most often you have to have a dose prior to become sensitized to these allergens, although that's not always the case. Most often it can occur after the first exposure, but there's silent, some people can experience this after the first drug. We don't know the mechanism behind that. Again, this IgE, they sit on mast cells, and they're waiting for these particles to come by. Once they cross-link, they release all of their contents. Many of them cause vasodilation, which is they release histamine, causes hives, itching, things of the sort. Now, if you don't remember anything else from these immediate type reactions, if you're at all concerned about a reaction being anaphylactic, get a tryptase level within 3 hours. That's very helpful. Now, these take several weeks to come back, but leave that to us to tease out. What we do is get a tryptase level during that episode and then at baseline and compare them, and you can really tell whether it's an anaphylactic reaction or not. And this comes up a lot, especially in the perioperative setting where they're getting a bunch of drugs that can draw blood pressure, a bunch of drugs that can cause rashes. So actually the anesthesiologists here are fantastic about getting tryptase levels, and it's very helpful for us when we're teasing this out down the road. As you know, commonly implicated drugs, beta-lactam, it's becoming an increasing problem with chemotherapy. Monoclonals also can cause it, anti-epileptics, but just about any drug can cause this. So delayed reactions. This can be very complex, but the way I like to think about it is keep it very simple. Was it a mild reaction, which by far and away is the most common reaction, and the maculopapular rash is that reaction. And everyone in this room, I'm sure, has seen a maculopapular reaction. Very common. Generally, no systemic symptoms. Occurs 24 hours to several weeks after initiation of the drug. Unfortunately, there's no great test for it. It's a clinical diagnosis. Now, if there's some exfoliation, you're worried about Stevens-Johnson, TEN, a biopsy can be helpful in that clinical scenario. Treatment, you stop the offending drug. Now, we get patients from Moyer-Aiken in the CF clinic, and as most of you know, they have a ton of drug allergies. They have a ton of resistant organisms. So oftentimes, we're stuck with treating through these type of reactions. We use high-dose antihistamines, occasionally low-dose prednisone, and for the most part, we're able to get them through, and they're a very, very motivated patient population. So something to keep in mind. I love this study several years ago out of Switzerland. So they took 88 children with this delayed rash. They called it maculopapular, which I presume most of the cases were, although urticarial was discussed in a few cases. They actually challenged these patients with the drug 6 to 8 weeks later. Only 6% of them had the same reaction, meaning it's not thought to be a true, long-standing immune-mediated reaction. There's thought to be other components, including viruses and things of that sort. So The next category is severe rash, and you always want to ask these questions. Any severe exfoliating rash, they told you had a burn, anything involving the mucous membranes, genitals, that's something you always have to keep in mind, always ask about. Dress is another one of those, which can be life-threatening as well, where they get a severe rash. They also have end-organ dysfunction, in addition to the eosinophilia that goes along with the diagnosis. I'm not going to spend a lot of time on those because those are very rare, but again, that's why I always ask about a severe reaction to the drug. Another way to think about this, more for boards, is the Gell-Coombs classification. Again, these IgE mediated reactions are the type 1. Type 2 and 3 are also immunoglobulin mediated, but they're associated with the IgG and IgM. They're very uncommon. Again, I'm not going to talk a lot about those today. And the type 4 reactions, you can make these very complex. They can be mediated by monocytes, eosinophils, CD8 cells, neutrophils. But again, I like to keep it simple. Severe versus not severe. So this is a question we get a lot. What is the cross-reactivities of these beta-lactam groups, the penicillins, cephalosporins, carbapenems? So penicillin allergy is by far and away the most common allergy reported. Up to 10% of the population reports a penicillin allergy. And after being a hospitalist here several years ago, I'm sure it's higher in this hospital given the complexity, the amount of drugs people are exposed to. But when they do the studies where they do skin testing and actually challenge them, only 1 out of 10 of those patients, meaning closer to 1% of the population, is truly allergic to penicillin. Cephalosporins, it's a very hard literature to tease out. The reason being is in the 70s, early 80s, there was trace penicillins in the cephalosporins. So we really have to throw all of those studies out. A lot of studies have looked at, going through chart reviews, seeing penicillin allergy, but as we just talked about, most of those penicillin allergy patients aren't truly allergic. So there's very few good studies that do oral challenges or skin testing to penicillin. And of those, the cross-reactivity is thought to be very low, 1 to 2%. So much so that the American Academy of Family Practice, the American Academy of Pediatrics recommends using second or third generation cephalosporin if it was not a severe reaction. Again, thought to be very low. Similarly, carbapenems are in that same boat. Of the good studies where they truly classify penicillin allergy patients and then challenge them, again, 1 to 2%. So thought to be very low, not much higher than having a risk of another unrelated drug. Now, we have great testing for penicillin allergy. It's the one standardized testing. We do skin testing to other drugs, but they're not standardized like penicillin, and we do a ton of these, and I'm going to talk about that in a second. So, if someone comes into the hospital, it's the middle of the night, you have a million things to do, as far as checking this patient in, but if you want to start a second or third generation cephalosporin, asking 3 easy questions. Did you ever have an immediate reaction after the first dose with wheezing, chest tight, and shortness of breath? Did you have a severe delayed reaction, meaning blistering, mucous membrane involvement, genitalia involvement, or did they ever tell you you had problems with your lungs, liver, etc.? If those are no, and skin testing isn't available, it's very safe from a medical legal standpoint to give a second or third generation cephalosporin. To be honest, even first generation cephalosporins, there's not a lot of great evidence, but these societies have not come out strongly for that yet. That may change in the coming years. Now, if you're unsure, they have some components, maybe you had some shortness of breath because a lot of these patients get nervous as well. You can give a graded challenge. What we usually do is start with 1/100th of a dose, watch them for a half hour. If they do well, give 1/10. Do well for a half hour, give them full dose. We do a lot of this in the CF patient population to try and tease out their drug allergies. Now, if it's strongly suggestive of an IgE-mediated reaction, the easiest way to do that is do penicillin skin testing, but you can either give an alternate drug or you can desensitize, and I'm going to talk about that therapy as well. So, pre-pen testing. It's a fantastic test. We do several a week, and it's very satisfying because in my experience, 97-98% of these patients were able to get penicillin off their allergy list. Pre-pen, it's been around a while. However, it was off the market from about 2001 to 2009, so we're thrilled to have it back, and we use a ton of it. It only predicts immediate reactions, but as I talked about, if you rule out those serious delayed reactions, the maculopapular rashes are not often reproducible, so we do not worry about that much. when we challenge people in clinic, we give them amoxicillin, and then touch base with them 2 or 3 days later, and almost no one's had a delayed rash to these. So I want to bring up the project that Matt Altman and myself, as well as Rupali Jain and Paul Pottinger in the Antimicrobial Stewardship Program have been working on. Starting about 5 months ago, every time that someone orders Aztreonam, we get an alert to review the chart, basically. The reason for that is often Aztreonam is not a great drug to treat these organisms, and most often, it's by far and away much more expensive. So Rupali did a cost savings analysis, and if we had people on ceftazidime instead of Aztreonam over a 6-month period, it saves about 14 grand. I don't know what our most recent figures, but I think it's close to 8 grand that we've saved in 4 or 5 months. So it does make a difference. Oftentimes, we run up, get a quick history from the patient. We don't need to formally see them. Recommend they receive this other drug. If the patients are interested and it's not a clear-cut story, we'll often ask if we can do pre-pen testing in-house. So if you hear from us after ordering Aztreonam, we'll always ask if it's something you're interested in. If not, that's fine, but most people have been pretty receptive to that. Now, as far as testing to other drugs, we do have protocols that we use. What we do is use non-irritating doses in normal individuals. Now, if it's positive, it's helpful. If it's negative, it doesn't completely rule out an IgE-mediated reaction moving forward. So it can be tricky in those standpoints. But I do want you to remember pre-pen, because that's by far and away the most common allergen, and we have great testing for that. Moving on, that sulfa allergy issue. So sulfa allergy can be classified into 2 different categories. And again, if it would be better to have sulfa allergy versus sulfa antibiotic allergy, because they're very different. Antibacterial sulfonamides have an arylamine group, which is thought to be the main component of the allergic reactions, whereas sulfonamide-containing components such as furosemide, hydrochlorothiazide, and the rest that you can see on the list do not have that component. And in our studies, there's really no cross-reactivity that anyone's noted that's significant. So the one issue is sulfasalazine, and then when that's broken down, it can form somewhat of an antimicrobial component that theoretically people can cross-react to. Now, there's no great evidence, and actually people with sulfa allergy to antibiotics, I will give sulfasalazine because I treat it for idiopathic urticaria. Some people are more cautious, but I'm fine giving sulfasalazine as well. So what do you do with a drug allergy? Obviously, you can avoid, and in the middle of the night when I was a resident, that's oftentimes what I did. Knowing the cross-reactivity, and from those previous slides, I hope you realize that the cross-reactivity in a lot of these drugs, especially penicillins and cephalosporins, carbapenems, is very low. You can do a drug challenge procedure. We do a ton of this. Give a low dose, watch them for a half hour, give a little higher dose, watch them, and then give full dose. Is there great evidence for that? No. But it helps us sleep at night. And after doing this for close to 6 years, I've never run into an issue with it. Again, it comes down to history. And if you're doing that, usually try and get us involved. We have more time to look into that component. Drug desensitization, you guys have probably heard of this or performed it in the past, where you can actually give anyone, if there's concern for an IgE-mediated reaction, you can give them the drug, and we have protocols for that, which I'm going to talk about. Also classifying pseudoallergy, because it has a lot of implications on how to use those drugs, and I'll talk about that as well. So, my colleague Matt Altman trained at the Brigham, where a lot of this work has taken place in desensitization protocols, and they have basically an Excel spreadsheet that you can plug any drug in if there's concern for an immediate reaction, and they have tremendous success desensitizing, even if it's the actual drug they reacted to. So we do have that protocol, and we may have this as part of our computer ordering system, I'm not sure, in the future. For now, we do have desensitization protocols in ORCA. So if you're thinking about ordering that, just let us know, give the fellow or myself a call, and we can help you order it and go through it. And again, if anyone has ever had a severe blistering rash, desensitization is not the way to go. We got a consult from Children's a few weeks ago that wanted to desensitize in a case of duress. Luckily, we got to him before that, because that could have been catastrophic. But for the most common allergies, meaning the IgE, these works very well. So back to our first case. The rash occurred more than 10 years ago, and that's another thing. The longer it's been since they had that previous reaction, the less likely it is to occur. She did not have any severe blistering rash involving the mucous membranes, doesn't remember receiving epinephrine. You wanted to use a third-generation cephalosporin in this case, use it. If there's any questions, let us know. We're on call at all times. Our fellows are on 24/7. If it's at night, make sure you talk to them, please. So, no, we are always available, and usually we can answer those questions. Similarly, this next case, for Lasix, the cross-reactivity with a sulfa antibiotic, again, there's no evidence saying there's significant cross-reactivity. So you can safely give that drug. Next category is pseudoallergy, and it's something we've all seen as well. It's a similar reaction to an IgE-mediated reaction, but it acts fairly different. We'll talk about that. The complete mechanisms of why these reactions occur to things like vancomycin, opiates, in contrast, are not completely understood. But the difference between these is oftentimes by slowing down the rate and pre-treating with antihistamines, oftentimes steroids, you can get them to tolerate the drug. Now, if this were a true IgE-mediated reaction, that would not be possible. But just knowing the propensity of these drugs to cause these reactions, you usually have a pretty good idea. So we all know red man syndrome. We've all seen it. Flushing and pruritus, mainly located on the upper body. And it's usually rate-related. You know, in a lot of studies have shown the faster you give that drug, the more likely they are to have that reaction. And it can be potentiated by other drugs, such as opiates. Now, there are reported cases of IgE-mediated anaphylaxis to vancomycin. I don't think I've ever seen one. Paul says he's seen a possible case. So they all are out there. And the way to differentiate that, make sure they're not having whole-body diffuse hives. Make sure they don't have severe bronchospasm. Some people do develop some bronchospasm, but if you're having to take them to the ICU, things of that sort, that would be something we could look into. There is skin testing available. We don't do it a lot, but we occasionally will skin test vancomycin. But by far and away, that red man syndrome is more common than the IgE-mediated reaction. Similar to opiates, it's thought to cause nonspecific mast cell degranulation. Most of the time lowering the dose, trying a different drug, they're able to tolerate that, and we do a lot of those type challenges in clinic. Radiocontrast, something we've all dealt with as well. You treat with steroids, antihistamines, most of the patients do very well. Now, we get these consults 2 or 3 times a year, and I'm not sure where this got propagated in the literature, but it's been said that seafood allergy or iodine allergy, which you can't be allergic to iodine allergy since it's an element, we get these consults, and there's no validity to that. So if you ever get called about a patient, we can't do this scan because they have a seafood allergy, that is not the case. Okay. Switch gears a little bit to asthma, and this has some issues with drug allergy as well. And some of you may have seen these patients. They're called triad asthma, aspirin-exacerbated respiratory disease, the allergic triad. There's about 10,000 names for this condition, but we're trying to focus on aspirin-exacerbated respiratory disease. And we see a lot of this because Greg Davis, one of our colleagues in ENT, gets a severe sinus patients with nasal polyposis, usually eosinophilic in nature, subsequently develop severe asthma, and have a worsening of both asthma and nasal symptoms on COX-1 inhibitors. This is a fascinating disorder. These patients do well most of their lives, and then they suddenly come up with what appears to be a viral infections in their 20s, 30s, and they never recover. They have these chronic eosinophilic polyps, which bother them a ton. They can have asthma with FEV1 in the 50s, come in wheezing, but their lungs don't bother them. It's their nose because they can't smell and taste. A lot of the patients that get admitted, a lot of patients get admitted to the ICU actually have this because they get an exacerbation triggered by a viral infection, and then they accidentally take an NSAID, and that pushes them over the edge. So the treatment, it's thought to, I'm not going to torture you down here with the arachidonic acid pathway, leukotrienes, prostaglandins, are thought to have a major role in this. The exact pathophysiology has not been totally figured out, but we treat with leukotriene blockade. But the other thing I want you to remember, if you see these patients have frequent nasal surgeries, polypectomies, have severe asthma where they're getting hospitalized requiring frequent prednisone, we actually do desensitize them. It's a 2-day procedure. We do as an outpatient down on the 3rd floor where we slowly increase their dose. We give them nasal Toradol for a while, give them subsequent aspirin, have them back the next day, and get up to 650 milligrams twice a day of aspirin. And they do very well. There's great literature out of Scripps down in San Diego that these patients do very well. And in our experience here, that is the case as well. So it takes a motivated patient. If they miss their aspirin for more than 2 or 3 days, they have to come in to have that procedure repeated, which is expensive and very time-consuming. Some questions. So once someone is desensitized, are they then able to receive that drug in the future without problem? No. Once they're off the drug for more than 2 or 3 days, they have to be desensitized every time. Now, drug challenges, which is why I talked about giving a low dose every half hour just for 3 doses, that's different. That means they will tolerate the reaction moving forward. So if a patient had anaphylaxis to Zosyn, what you would do is choose another one in that class, right? No, you can desensitize even if we know their IgE-mediated anaphylaxis was to Zosyn, and it works very well. So if someone had DRESS, Stevens-Johnson, TEN, you can get those drugs, but only if desensitized. No. Stay away from those drugs. We won't even skin test them. There's case reports of skin testing to those drugs triggering DRESS and Stevens-Johnson. So another form of, I guess, pseudo-allergy, you call it, is ACE inhibitor-induced angioedema. So angiotensin 1 is converted to angiotensin 2 in the kidneys, and angiotensin 1 goes to angiotensin 2 in the lungs. Sorry, I said that wrong. Angiotensinogen goes to angiotensin 1 in the kidneys. Angiotensin 1 goes to angiotensin 2, and that's converted in the lungs. What ACE does is block the production of angiotensin 2. The reason we do that is that's a vasoconstrictor, which is why we use it in hypertension, why we use it in kidney disease. But another thing angiotensin 2 does is inactivates bradykinin. Bradykinin is a key mediator in angioedema. Now I have a next slide to go over why that is. In other words, if you can't break down bradykinin, you can set them into these angioedema episodes. Another question we often get is, what's the cross-reactivity with angiotensin receptor blockers? Now, they work downstream. These patients still have angiotensin 2 because they're not blocked by this ACE, by the ACE inhibitor. So theoretically, it should be very low. That being said, about 5% have been reported in some of these studies. And whether these patients are idiopathic angioedema, whether they're hereditary angioedema patients, it's unclear. But bottom line, I tell people, if they have an absolute indication for either an ACE or an ARB, I recommend starting them. I'm sorry to torture you this early with the complement cascade. But it's a component of the innate immunity, and it interacts with both the adaptive immunity. The classical complement cascade is triggered by antibodies. Unfortunately, these agents were found at different times, so they're not labeled in order, which would make our jobs a lot easier. But once this goes off, it also interacts with the contact system, and the end-stage mediator of all this is bradykinin. So for patients with hereditary angioedema, and you may see these patients in the hospital, it's not subtle when they swell. Their hands look like boxing gloves, their face blow up, and you can't even recognize these people. So most of the people in this room have C1 inhibitor, and basically I describe that as being the brakes in the system. Once any inflammatory, whether that's trauma or whether that's an infection, gets going, this is the brakes of that system, and these patients don't have that. Now, there are therapies for these patients. One of them is Cinryze, another one's Berinert, which is basically giving them C1 inhibitor. They work fairly well, but they're astronomically expensive. Some people do it prophylactically, but insurance won't pay for it, so we often have to use those as an as-needed therapy. Now, in the past several years, there's 2 other agents that have come on. One's Calbitor, which is a kallikrein inhibitor, and then the one that we're really excited about is Firazyr, which is a bradykinin receptor antagonist. So theoretically, this should be something that could use for both ACE inhibitor-induced angioedema and hereditary angioedema, and the studies are still backing this up, but there's a lot of case reports saying this is effective. Unfortunately, we don't have that on formulary here, but letting us know these patients are in, oftentimes we can set them up with Firazyr. It's a nice drug to use. They can give it to themselves at home. It's not an anaphylactic risk. It's reasonably expensive, but it's less expensive than them having to come into the ER. Now, just totally switch gears. What a lot of people don't realize that we do, especially the younger trainee and eye docs training in a place where there is immunodeficiency training, is immunodeficiency. When I was a resident, my adult workup for immunodeficiency was HIV. That's it. That was it until I started studying this in my 3rd year. So I want to start with a case. I actually saw this patient yesterday. I've been following her for a couple of years. Past medical history of bipolar disorder. Pretty normal kid up until about 15 or 16. Developed asthma, wheezing, shortness of breath, was treated. Did all right. Again, that's not that unusual. Developed 4 to 5 sinus infections per year. And, that, along with asthma, is somewhat unusual, but we do see that. And then had episodes of pneumonia. And whenever I ask about pneumonia, I said, did you have a chest x-ray? If you ask, oh, yeah, I had pneumonia last week. So you want to ask about a chest x-ray, whether it was a real bacterial component to it. Then some other weird stuff started popping up. And this was over the course of 10 years. And she saw countless doctors for this. Shingles, recurrent otitis media, which, unless you're a kid, is not something that is common. Recurrent dental caries. She actually had to have all of her teeth removed recently because her cavities were so bad over so many years. So, to take you back to the beginning, the first pediatric immunodeficiency was defined in 1952 by Bruton. He's at Walter Reed Medical Center, and he characterized an 8-year-old with this history. Recurrent sepsis, mainly with pneumococcal organisms. He was having recurrent right upper lobe pneumonia, otitis media, epidemic parotitis, whatever that is. They repeatedly gave him this vaccine, but he did not respond at all. So in their workup, they noticed that he had much lower gamma globulin than the controls. So astutely, they actually gave him gamma globulin here. And his levels shot up, and after being started on regular immunoglobulin, they actually gave it sub-Q, which is interesting because that therapy is making a real comeback. He did very well for many years. He didn't know it at the time, but what he diagnosed is X-linked Agammaglobulinemia, which is a defect in the BTK. Again, that's not important, but in other words, these patients can't form B cells that respond appropriately to they can't form appropriate antibody responses. Now, fast forward 60 years. Our boards have gotten a lot more complex in regard to this. Now there's over 270 monogenic primary immune deficiency diseases. They've classified it into a lot of different classifications. Now, these first two are severe combined immune deficiency. The classic case is Bubble Boy. We probably all remember that from Texas many years ago. This used to be uniformly fatal, but there are new therapies. And these kids can do very well if caught early. So I'm going to talk about that in a little bit. B-cell immunodeficiency. These are the ones that you will see in clinic. These are the ones that you have a chance to diagnose and conceivably save their lives with some very easy testing. Phagocytic disorders, we'll go over that a little bit. They can present in adulthood. There's a case of a 22-year-old here that had CGD diagnosed. There's new defects in the innate immune system if there's time. See how I'm doing. We may be able to get to those. Complement deficiencies. Again, complement deficiencies are very rare except on your boards. So, and then some other rare immune deficiencies. So, when I came into my first day of fellowship, I trained in internal medicine. About half our fellows are pediatrics trained, half in internal medicine. I walk into the hospital, and Troy Torgerson, who's fantastic, gave me this slide. And actually, to some extent, I still think of immune deficiency in this way. There's the adaptive immune system. They're the B cells. They're the Air Force. They make these heat-seeking missiles that can neutralize bacteria, neutralize viruses, things of that sort. There's the T cells. They're the generals, the CD4 cells. Obviously, that's what HIV goes after. There's the assassins, the CD8 cells, and the psychologists, the FOXP3 CD4 cells, which are involved in autoimmune intolerance. Phagocytes, I'm going to briefly go over that, although usually those are detected early. They're the Marines. I like that. They're the first one in, the last one's out. And then the complement, the landmines. Again, fairly rare, but I'll go over it briefly if I have time. Back to this first case. Now, the guy that caught this was actually my intern when I was a third-year resident at the University of Colorado. So I talked to him. I said, it's obviously all that incredible training that I gave you as a resident. And he told me he didn't remember any of that, so he picked it up on his own. But very astute pickup and probably saved this girl's life. This is common variable immunodeficiency. You will see this. So with any B-cell immunodeficiency, recurrent sinopulmonary infections, sepsis, GI infections, the diagnosis is fairly easy to make. IgG, IgA, IgM. We check their response to immunoglobulins. You can leave that to us. If you're at all interested, what we do is check tetanus antibodies, pneumococcal antibodies, and then immunize them and see how well they respond to the pneumovax. Lab workup, again, is fairly simple to do, a basic workup, and you can pick up a lot of the more severe cases just doing immunoglobulin Pathology in these cases is not clear. I think there's going to be a lot of different mutations or multiple mutations that are responsible. There's about 7 mutations that account for less than 10% of CVID, but hopefully that'll change in the next few years. Now, these patients don't always end up in ID clinic. They end up in heme clinic. A lot of them have autoimmune hemolytic anemia, ITP, a lot of those manifestations. They have rheumatoid arthritis. They have lupus. There's a lot of other things. They end up in Pulm clinic. Another patient I saw yesterday has granulomatous interstitial lung disease that goes along with this. Unfortunately, it's a poor prognostic indicator, but the pulmonary folks are managing it very well, and she's leading a very normal life at this time. So, again, making it simple, trying to keep these into specific patterns so you have an idea of how to work them up. B-cell immunodeficiencies, basically the sinopulmonary tract, is where most of the problems occur, at least initially. Recurrent sinusitis, pneumonias, documented by chest x-ray, chronic or recurrent gastroenteritis, and the classic is giardia, unless they've been drinking out of mountain streams or something like that. Unexplained bronchiectasis, this should always be in your differential diagnosis as well. Common adult B-cell immunodeficiencies, we talked about CVID. Now, IgA deficiency is an interesting one. So it's very common. It's thought to be anywhere from 1 to 100 to 1 to 1,000 of the population, and most people are asymptomatic. We see these patients because in celiac screening, they get an IgA, they're low, they send to us, and a lot of them are like, why the hell am I here? Because they're totally asymptomatic. Where there are some people that are symptomatic, and this could be the beginning of what's developing into more of a CVID-like phenotype. So we will follow these patients depending on their clinical course. Specific antibody deficiency. This is something that's being developed more and more, and especially the patients that have severe infections will oftentimes see how well they can form antibodies. Again, that's checking their response to vaccines, and usually we do that, but if you're interested, I have a slide at the end on this. Workup for B-cell immunodeficiency, CBC with differential, immunoglobulins, specific antibodies, T and B-cell subsets with attention to CD19, CD20. I'm not going to spend a lot of time on T-cell disorders because those mainly present in early childhood. In a kid with PCP pneumonia, that's immune deficiency unless ruled out. You can do a pretty nice workup, CBC, T and B-cell subsets, and then mitogen studies, basically seeing how well their cells respond to things that they should. Phagocytic disorders, these patients present with pneumonias, skin abscesses, which is different, osteomyelitis, and a lot of these patients are, at least in kids, are initially classified as inflammatory bowel disease because it's the same type clinical picture. Burkholderia, Aspergillus, Staph, Serratia, Nocardia, those are the classic organisms with phagocytic disease, and you can catch these patients even into their 20s and 30s. Again, I apologize, here's the complement cascade. So, at the initial parts of the complement cascade, I should mention, C5 through C9 forms the membrane attack complex that basically comes in and blows a hole in the pathogen. If you have defects in that part of your complement cascade, the classic board answer is you have recurrent Neisseria infections. If someone comes in with a Neisseria meningitis, you should check complement levels because that's, especially in an otherwise very healthy person. So late complement, again, Neisseria is the board answer. Early complement's interesting. They often present very similar with encapsulated organisms, but they have a very high rate of autoimmune disease. Up to 50% of C4 patients have lupus. So I know a lot of our rheumatology colleagues will get a CH50 in the workup of this disorder. But common things being common, antibody deficiency by far and away. And the Jeffrey Modell Foundation for Immune Deficiency has come up with 10 warning signs. And if nothing else, paying attention to this side of the talk, just know warning signs of immune deficiency. 2 or more ear infections in a year in an adult. And a kid, obviously, that's not the same. But 2 or more sinus infections in the absence of allergy. Pneumonia, 1 per year for more than 1 year. And again, you have to classify pneumonia. Recurrent viral infections, cold sores, herpes, warts, etc. Patients getting hospitalized for severe infections. Again, patients that aren't immunosuppressed. Deep abscesses. Again, this can be phagocytic disease. And and hopefully if I have time, and we'll see, I may not be able to get to my last few slides, but there's a new class of immune deficiency that predisposes to recurrent mycobacterial infections. So, again, if you're at all concerned, send them to us. We're happy to do the workup. But if you're in an area where you don't have immunology, go through those warning signs and try and classify it into B cell, T cell, complement, phagocyte. So if they have meningitis, sepsis, pneumonia, an easy workup, again, IgG, A, M, and then specific antibodies to tetanus and pneumococcus. History of Neisseria meningitis, autoimmunity, CH50. Now there's alternative pathway, things of that sort. Don't get involved in that. Send them to us if you're still worried. CH50 is an excellent test. Basically, you have to have all the components of the complement cascade to have a positive test there. And it's a great, easy way to rule that out. Now, if you have PCP, recurrent viral or fungal infections, again, CBC, HIV, T and B cell subsets, and mitogen studies are an excellent way to rule out at least the more serious forms of this disease. And then, as far as a phagocytic workup, recurrent fungal infections, abscesses, CBC with diff, an oxidative burst, which looks for chronic granulomatous disease, another easy test. It gives us a ton of information. So, again, if you're in the middle of nowhere, you want to perform that test, we're happy to do so. It breaks up our rhinitis workups, so it's very nice. So treatment, we found these patients. What the heck do we do with them? IVIG. It works very well, especially for the most common adult immunodeficiency. We dose it usually 400 milligrams per kilogram every 3 weeks. Most patients do very well. Now, as I talked about that first case with Bruton, they gave it subcutaneously, and that's really making a comeback. And frankly, we like it. With IVIG, you get a waxing and waning, depending on when you got your infusion, whereas this provides a steady state level and depends on, what patient preference. Some people like doing their infusions at home, whereas other people like every 3 weeks having a nurse come in and give them their IVIG. Again, really up to patient preference. We often will use subcutaneous if they have a history of CHF or chronic renal insufficiency as well. We'll often use prophylactic antibiotics, and especially in IgA deficiency. And then gene transplantation and gene therapy. So I think I have time to quickly go through why this field is becoming more and more complex and why our boards are becoming more and more complex. You probably all heard of toll-like receptors, which is a class of proteins in the innate immune system. They recognize patterns of certain microbes, whether that's bacteria, viruses. It's an ancient form of the immune system, but still we need that to help keep us healthy. So I had a patient in residency that was very healthy, but came in, 30-something-year-old, severe HSV encephalitis, and he was institutionalized after that. It was so bad. So my question is, why is someone that was so healthy otherwise, when 60% of the population, don't quote me on that number, but a good majority of the population has HSV1, why do so few people get HSV encephalitis? So they did these studies looking at poly-IC, which is double-stranded DNA, basically, and it fires up these cells. And they found in these patients fibroblasts, CD8 cells, and NK cells. It was very important to CNS immunity. And they had a diminished interferon gamma and interferon beta response in those patients. But in the periphery, in similar cells, blood dendritic cells and keratinocytes, those patients could signal through the poly-IC, meaning they did respond. It was not through a TLR mechanism, because the TLR mutation was the same, but it's an alternative mechanism by which they're able to mount a response. So in other words, in the periphery, they're protected against HSV, but in the central nervous system, they're more likely to develop HSV encephalitis. So your toll-like receptors, since they found the TLR3, they went downstream. They looked for something called UNC93B, which is a component of the endoplasmic reticulum. These patients similarly have HSV encephalitis. They found TRAF, similar presentation. They've also since found one in this molecule, TRIF. So, these patients with just HSV encephalitis, it should be looked for. There's an assay through National Jewish that will often run. Now, there's other components of the TLR system. They respond to bacteria, they respond to single-stranded DNA, and a lot of them signal through the same lower pathways. In general, the lower they are, the more pathways they involve, the more severe the immune deficiency. Whereas you can see these oftentimes that don't present in adulthood, these are more likely to be found in childhood where they have severe bacterial, viral infections and things of that sort. So lower down in the signaling cascade, the more clinical relevance it had. Now, while this is sexy stuff, you get your paper in Nature, you get to go around doing talks, these patients are very rare. I've looked for it a few times, have not found one. Common things being common variable immune deficiency, and I've had 4 patients that I've seen with CVID before they were diagnosed, before they were put on IVIG, that had HSV encephalitis. Interestingly, 2 were lawyers and could no longer practice afterwards. So, one more case. One of the first cases I saw as a fellow walking in there, I knew I was in over my head, was a 48-year-old female from Thailand with osteomyelitis with atypical mycobacteria. Her immune workup was totally normal. But what Troy Torgerson told me was to look up the literature on anti-interferon antibodies. And there's a study recently in New England Journal showing that 85 patients with disseminated non-tuberculosis mycobacterial infections or severe Salmonella, Burkholderia, Cryptococcus, Histoplasma, Penicillium were tested. Basically, they took their cells and tried to stimulate them in the absence of serum, and these cells were able to signal normal. They had a normal interferon gamma response, but when they took normal people's PBMCs and put the patient's serum in with it, those cells could not respond. And it's thought to be due to an antibody to interferon. So identifying these patients is important because how we actually treat them is with rituximab. The patient got them rituximab, and all her infectious issues have since improved significantly. Again, 270, we did this talk a couple of years ago. I was reviewing Troy Torgerson's talk. It was 150 at that time, so several mutations a month are being found, mainly because of the next-gen sequencing and things of that sort, and a lot of that's been done here. There's a change in concept. These patients used to be early onset, life-threatening, usually didn't live to adulthood, and that's totally changed. The boundaries of PID have expanded, and now it includes autoimmunity, autoinflammation, things of that sort. So, if I have time, I just want to come over one more case. So I was on call last year at Children's, and of course it's Friday afternoon. I get a call about 4 from the newborn screening lab saying, we got one. This patient had common variable immune deficiency, severe combined immune deficiency, or the bubble boy disease, which, and again, is uniformly fatal. Here's the other famous bubble boy who was much meaner and, from what it sounded like, much older. But no, this doesn't pertain to us from, at least an internal medicine standpoint, but if you're going to be having kids in any of the whammy states, this does pertain to you. Now, if we identify these SCID patients early, they're very treatable with gene therapy or transplantation. Now, it's very high mortality if they become infected. A sad case a few years ago. Kid, 3 months, had rhinovirus. Brought him into the hospital. We were going to transplant him. But unfortunately, we just could not cure that rhinovirus with him, and he ended up succumbing to it after 2 months in the hospital in the ICU. So it's imperative that we find these kids before they become infected. So there's a newborn screening. It's on the dried blood spots. I got to go check out the lab. It's fascinating. And what they look for is something called TREX, T-cell receptor excision circles. So all of us in this room, and I don't see any toddlers or anything like that, have a very low number of TREX, because as cells divide, the number of TREX decrease significantly. But in patients like these newborns that don't have a significant amount of T cells, this is an easy, early way to pick this up. Newborn screening began in Washington on 1/1/2014, and we found a lot of interesting things. A lot of states are now developing this. It's been shown to be cost-effective, because once these kids get infected, they're in the hospital for months and months. So, in summary, drug allergy. If you take nothing else away, if you're at all concerned about anaphylactic tryptase level, and again, that's a board question. I did have that on my boards as well. In penicillin allergic patients, rule out those severe reactions, the immediate reactions versus the severe delayed. And you can use second or third generation cephalosporin in those folks. We're available 24 hours a day. We're in clinic 5 days a week, kind of lurking in the shadows, so we're always around. Angioedema, let us know if these come up now. Again, we don't have that Fierzier treatment here, but we can set it up for them as an outpatient to prevent future admissions for this. And again, immunology, keep us in mind. Know the warning signs for primary immune deficiency. And again, this diagnosis is expanding very quickly. So if anything seems funky, let us know. Now, I know as having been a hospitalist here, I think I had 9 patients on my service at one point, and all were transplants. So there's obviously other reasons to be immune suppressed, but in an otherwise normal individual, make sure you keep this stuff in mind, because early diagnosis can help save their lives. Now that patient that I saw, that I ran over the case, she has severe bronchiectasis, all her teeth had to be pulled. A lot of different things have come up with her. If we could have found her 5 years earlier, I think she would have done much better, although she's doing reasonably well at this point. Again, at the end of the year, I'm going to be talking more about outpatient-based issues, allergic rhinitis, food allergy, asthma, urticaria. So if you're interested, that's broadcast, and it's at 7 o'clock on May 6th. And I really appreciate you guys' attention.